All right, I think we're going to go ahead and get started. Hello, everyone. I'm Alex Folk. I'm a data analyst with KFMC. And I am here to introduce Mariah Chrans, who's the program director at Cradle, Kansas City. And she has many other accolades, but I won't go into detail on those right now. I'll just welcome her on.
Thank you, Alex. I'm going to do my best to stand in front of the microphone because I'm a pacer, and I flail my arms, just so you know. I'll try not to be too distracting. So we're going to talk about data, maternal health data specifically, but there's a caveat to that. There's only one slide that actually has data on it, because we're going to talk about why there's only one slide that actually has data on it. Like Alex said, my name is Mariah Chrans. I'm program director at Community Health Council of Wyandotte County, where I oversee the majority of our public-facing programs, including our community health worker and maternal health initiatives. And one of the pieces of that work was developing Cradle Kansas City, which is a systems change initiative that originally was looking at policy and shifted to data based off the feedback of the members of the collective, which is about 120 people back in 2018, when they decided that we need to focus on data. Over the years, we developed our data sharing network, which we'll talk about the timeline in a little bit. But first, I want to jump in and talk about why data is a challenge. So there's a couple objectives. I have no disclosures. I'm not making any money off of this other than I'm employed by CHC. There might be a spelling error or two in here that I did not catch, so I apologize ahead of time. And I talk really fast, so if you need me to slow down, just say, "Slow down, Mariah," or repeat that, and I'm happy to do so. So first, I want you to find a buddy, find your data bestie, and ask yourselves, do I have a data problem? Because you probably do. So who is your data nemesis? If you have one, does it have a name? Does it have a theme song? If you could banish it on a desert island, who would you send with it? What would you do? What's the problem you'd send with it? And the reason I start with these questions is because this is what we started with the collective when we started talking about data. It was like, what is the problem here? Why do we have such a big problem collecting maternal health data, and why can't we find accessible data? So just take a minute, turn around, find somebody, find a data bestie, it doesn't matter who it is, go across groups of 3, and just ask, what's your data challenge? What is the one thing that just, when you hear about data or you can't get data, you're like, oh my gosh, it's this one thing. What is it? Because we all have it, but what is that one thing? So just take a minute and do that. Okay, about one more minute. All right. So does anybody want to say what their data nemesis is? Yep. Where's it at? Great one. I love that one. I agree. Anyone else? When do you stop gathering it? Great question. That's a good one too. Oh, how it's bundled together. You don't necessarily get what you're wanting in that time period. So for me, it's old. By the time as a CBO, a community-based organization, I can access data, it is so outdated, I can't even use it to determine what we need to do or where we need to focus. That is a significant problem. And it's not unique to us. That's just it's a problem. And when we get data from the state or from government entities, it's lumped together in years, right? And often it's 5 to 10 years old. So that doesn't help me either, because the maternal health landscape today is vastly different than it was 5 years ago or 3 years before that. So we really have to think about what are we wanting to do and why are we wanting this information and what's it going to do for us, not just to check a box or to write a report, but what is it really going to mean to benefit our work. So Cradle KC is trying to address this issue. And a couple things that we do, when we do our work, we really focus it within 5 areas, and we have to, because maternal health work is hard. Community health work is hard. It can be very depressing. We're looking at mortality, morbidity. We're looking at challenges. We're looking at individuals who are struggling to interact with a system that really doesn't want to interact with them. So that's really hard work and a hard weight to carry. So we have to have joy. We have to have clarity. We have to have hope. We need to have good data so we know where to go. And we need to take action. We have to stop doing what feels good, but may not actually be for the greater good. And that's one thing we do really well collectively in nonprofits. We love to do things that feel so good to do, but may not actually do good work long term. It's putting a Band-Aid on a leak. It doesn't actually fix the problem, because sometimes the stuff that fixes the problem doesn't feel good in the moment. So we want to make sure we're taking action that's actually doing good long term and may not immediately feel very good when we do it, which means sometimes it's really hard. So data. Here's my one data slide. This is all data you get, all right? So what do we know about maternal health? What do you think 55th is? We're ranked in for what? Yes, maternal mortality. This is our ranking globally. We are below some developing nations. Just keep that in mind. So what do you think 21st is? That's Kansas's ranking nationally. And because we're in the metro, I have Missouri on here too. Missouri ranks 40th. Missouri is a very unsafe place to have a baby. How about this one? We rank 55th, the US ranks 55th globally according to the CIA fact book. And that's an improvement because it used to be lower. So we've improved slightly. And we spend more per capita than any other country, 3 times on health. We have some of the most advanced technology in this country. And that's where we rank. So 173rd, that's infant mortality globally. Out of a little over 230 countries, that's our ranking. And that is not based on race. That is total. So it flip-flops between the top 5, usually include Norway, Japan, some other European countries, but Japan's always in the top 5. So, I mean, there's a lot of things we could talk about that, but why? There's a lot of things we could go into. But really, we just need to look at where we rank. So Kansas is 20th in the nation. If you break it down for Black and brown babies, we're the most dangerous place. 34th is Missouri, the ranking. So it's just really important to know as a whole for everyone in our nation and everyone within our states where we rank. And this is the most current data that I could get from the CIA World Factbook, which is kept pretty up to date. America's Health Rankings, County Health Rankings, those are the sites that I go to for current data, because I cannot get it from other entities that's current. So in current meaning within 2 years old. So I can't get the data I need to get from my state to show where I'm at because it's not current enough to show where I'm at. Well, there's all kinds of reasons why. We'll talk a little bit about it. So the backlog. So what we don't know, we do not know for the state, for our nation, for the Kansas City region, the current state of maternal health. We do not know that. And part of that reason is because the data is fragmented. Everyone has their own data. Hospitals have their own data, hospital associations have claims data, MCOs and payers have their data, organizations have their data. It doesn't all feed into the state, by the way. It feeds into different sources, if it feeds into anything at all. What is happening? Well, I wish I could tell you. I can tell you there is great work being done by a lot of small groups, but their data isn't going anywhere. It just stays within their organizations because they're not part of any collective effort. They may not be funded by a state entity, so then they don't share it with the state. They may not be funded by a large funder or partnered with a hospital where it would go to that hospital, so there isn't a place for that data to go, but stays inside their walls. They also may not know how to collect data in a way that is structured so it's reportable, and they may not be collecting the right things to show the good work that they're doing. This is very common. They also often collect data based off what a funder has requested, meaning they're collecting very specific data points for multiple funders and reporting that to those funders, but there's no collective picture of the good work that's being done. And that doesn't mean it's a fault of that organization. Part of it is capacity. They just may not know how to collect data better. They may not have someone on staff who is able to collect and analyze and determine if they're collecting things well. They also may be doing it in Excel or on paper, because a lot of our smaller organizations don't have case management systems or EHRs. And while there has been some efforts to roll out universal platforms, those universal platforms are referral platforms. They are not case management software that can give you the information you need. We also don't know what's working because we can't tell because we're not collecting it. So we don't know what's working well and what isn't working well, and we don't know where we should focus. And this bottom one is super important because I'm in the Kansas City metropolitan area, so this is the framework I'm going to give you. We have a zip code in Johnson County that has a higher infant death rate than any of the zip codes in Kansas City, Missouri that have been focused on for 20 years. But no one is doing anything about it. No one even knows it's there, but it's there. It's on there, my sidewalk, you can find it, but there's no work being focused there because it's not part of the area of focus that we tend to pour all of our resources and money in. And why aren't we collecting information that would tell us that? Again, because there's no place or no group to do it, and there's a lot of competitiveness in this work, unfortunately. So, the breakup. We have to break up with how we collect data. I mean, we really have to. We have to break up with the fact that everything has to silo into a government entity that cannot produce the information in a timely fashion because there's too many things and too many barriers and too many places they have to go across. I mean, I co-chair the Maternal Mortality Committee for Kansas, and our reports are delayed because of 2 or 3 word changes, and it can take months to have those approved by the state. So our work for us internally gets delayed. Like, this is the bureaucracy that we're dealing with, and it's not the state's fault. It's collectively where we've gotten to. We are a risk-adverse society, so we want to put barriers in the way to ensure that there's no risk on us personally being taken. You know, we really don't understand what data can be shared, what can't be shared universally. When we're talking in these collective meetings with our partners, one of the big things that came up was people thought that their wait list or their client load, how many clients they have, was proprietary information because they don't understand data and they don't understand what can and can't be shared. HIPAA only applies to clinical data. It does not apply to social care data, and people don't realize that. PHI comes in there, but HIPAA and PHI are different. They're not the same, and there's a lack of understanding of that. And then proprietary information really isn't engaged at all. I'm sorry, there's no trademark secrets in working with families, but we tend to think that there is, and that breeds into the competitive nature of the work. So what are we going to do? There is a need for shared data, a desperate need for shared data. There is a need to understand what is commonly being collected and how it's being reported. So how many of you in here work within a program that provides direct service? A few. Like, if you provide direct service to anybody in the community. So you do assessments, right? How many of us are doing the same assessment? Probably not. How many of us, for a social driver of health survey, which ones are you using? Prepare? Candidate Health Communities? Did you create your own because none of them match what you want? That's the common thing. How are you collecting and tracking pregnancy? Do you collect by gestational age? Do you collect by trimester? Both are great. Both are great ways to track. You need both. But trimester alone doesn't cut it because there's a big difference between early second trimester and late second trimester. I mean, survivability alone. So there are huge issues on how we collect information, much less report it. And then, do we collect information that was actionable, especially when it comes to SDOH assessments or HRSN assessments or mental behavioral health assessments? Are we collecting information for surveillance? Because I bet you are, whether or not you know it. If you are not acting on every bit of information you collect, you are collecting to surveil that population. You are not collecting to serve them. Another big issue that we have seen on the community health worker side, but we also see it in maternal health too, is when we collect data off of our social driver surveys and we only take action if they screen positive for 3 or more. So you're telling me if they don't screen positive for 3 things, and everything on a SDOH, most things on a SDOH survey are pretty critical, but if they don't screen positive for 3, you don't do anything at all? So they're just gonna go hungry, be at risk of losing their house, and have no transportation because they didn't screen positive on loneliness? Like, why are we not acting on what we're collecting? That's a big problem. But we don't even know that collectively, how much we do that, because we don't share our information and there's no place to see that. The other piece that's super important about this work is it has to be community driven. And when I say community driven, I mean driven by the communities that we serve. Our data sharing network, when we developed it back in 2019, was developed from community input, so I'm talking residents input, from MCH professionals, maternal child health professionals, from providers, clinical and social care providers, from policymakers, everyone who came to those collective meetings, and a random graduate level marketing student who came to the meetings in 2018. I don't know why, but he loved it, and he came every quarter. But they're the ones who crafted how this should look. They're the ones that said, this is what we want to see, here's what we need, how are we gonna do it? They asked me to do it, which is not exactly how collective work works, but I went ahead and did it anyway. And we have to have one focus. All of these maternal health programs, they say they have one focus. Usually it's to improve maternal health outcomes. Well, maternal health outcomes isn't one thing, that's like a million things. So what's the one focus for this network? And we determined our one focus is the greater good. Can we close the health equity gap by doing something for the greater good? If we can't answer this is for the greater good, which means that sometimes we have to put away our egos and really truly work together, then it's not worth doing at all. It's not our work to be in. We'll help somebody else do that work. So, what is the greater good? This includes community-centric work. So our governance structure has community members engaged in it. It includes unified data. This is going to come down the road because first we have to collect the data, do a gap analysis to see what we're not collecting, how are we collecting and reporting information, and then determine what are some unified reporting metrics that should be part of the best practice. And I'll talk a little bit about why that's not the responsibility of Cradle, it's the responsibility of everybody who's sharing data in and doing the work, and we'll talk about that in a few minutes. We need to identify these complex challenges in health because the health outcomes for a family, for a pregnant person, for a parenting person, it isn't just that they had a healthy pregnancy or a healthy delivery, it's that the entire system of them is healthy. Does that mean that they need help with support with education? And I don't mean health education, I mean, do they want to get a GED because they don't have one or get a diploma? Do they need help and support with employment? Do they need help with transportation? Is their neighborhood safe to live in? Do they have sidewalks? Do they have street lights in their neighborhood? Where's the closest green grocer available to them? What does it look like for them when it's cold outside? Is the mom standing at a bus stop with her 2 kids in the winter and it's raining because she doesn't have a car and that bus is late? She's late for her appointment. They canceled her appointment and marked her non-compliant. Happens all the time. What are we doing with that piece? That's a negative health outcome. And there are many things that could have prevented that we can intervene along the way, but we don't know if we don't collect the data to share it. And then equity-driven decision-making. This means, like with our network, we are currently developing our application process to do your projects, and it is not me determining this, it's a group of people determining what that application is going to look like, and that'll be means tested back with the collective as a whole to say, yes, this is equitable, this is what we want. So, accessibility. One piece is to break down those barriers. When I want to get data, I have to do a couple things. Fill out forms that are long and ask questions that are not relevant for my work. Sometimes I'm asked to produce an IRB. I don't need it, I'm not doing research. This is QA work, I don't need that. But why am I being asked for it? And I gotta pay for it. And data is expensive, super expensive. Sometimes it's expensive for no reason, just to be expensive. And it's inaccessible sometimes. Is it gonna come in a format that I can utilize and I can work with? I mean, I'm a CBO, I'm out of grad school, I don't have a license for SPSS anymore, and nor do I want to purchase one because it's very expensive. So what kind of data am I gonna get, and can I analyze it with what I have at hand? Can I use the systems I have at hand to do this work? And maybe an organization doesn't have anyone who even knows how to analyze data or interpret it, and they need support with that. And who's there to help support them at no cost? Stakeholder empowerment is super important. The people that are sharing data have to be a part of determining what this looks like. And that stakeholder also includes a community member because it's their information on them that we're asking for. And then how do we harness the power of shared data? What does that look like? And that comes into reporting and what types of projects are going to be allowed within the network. So it's important to identify that there are certain collective successes that we can all put up and say we did this together. And part of that is this data network forming. Part of that is saying we have a collection of data from various sources that people can access and analyze and answer their questions they have about maternal health. But it's also important to note that that success is all of ours. It's not one entity's or one person's. And recognize that sometimes there's gonna be work done by our partners that we're not a part of. That's gonna make a big impact, and that's okay too. It doesn't make them a competitor, it makes them a supporter. And we have to understand that and recognize that as fact as well. There needs to be enhanced collaboration with this type of work. If you are in maternal health and doing that direct service, or in community health in general doing direct service, how often do you and your quote-unquote competitor talk about the work that you're doing on a granular, open, transparent level? How often do we talk about our successes and the failures, because it takes a lot of failures to get to that success? Success doesn't just happen, it happens because you've tried and tried and tried and tried and tried. And we have to be okay with that premise, that we're trying and trying and trying. So failures are involved in all of this. We need to make sure that we are empowering and engaging the communities that is most affected. So when we typically think about data, we think about larger institutions doing data work, right? We don't think about your smaller CBO. So how do we take these learnings and encourage them to come in and say, no, this is your work too. Just because you have 5 employees and you are a very small group with a budget under $500,000 doesn't mean that you are not doing amazing work and you don't deserve to be involved in this work. Just because you don't have the skill set doesn't mean you cannot be engaged in this. We have to be intentional about bringing people in and empowering them to do this work. And I really don't like the word empowerment, but it fits best in this setting. And then harnessing the power of a large shared data source. And I'm sure a lot of you are thinking, okay, but how are we sharing this data and what does it look like? Who's owning this? We're gonna get to that, I promise. So when we talk about governance, this is where we're gonna get into how the network was established. So we're gonna talk about our governance structure. And one of the key pieces of this governance structure is that we are very transparent, as in, I will give you all of my documents. There is nothing I have done that is proprietary. There is nothing that I have done that is secret. Everything I have pulled down from government toolbooks, from AISP, from the Gravity Project, from the Charlotte Data Trust. They have been key figures in helping to get this network off the ground. It is open. It's an open book intentionally, so there is no hesitation in sharing or in joining the network or in wanting to access it for data. So before I go into what our governance structure looks like, I want to give you a little bit of history of the data sharing network. So in 2018, we started Cradle, and we had all these collective conversations with a bunch of entities, a bunch of people that did maternal health work, that big collective group I told you about. We did things like a prenatal care walkthrough, where we broke them up into groups, and we did a journey from the first positive pregnancy test to 1 year of birth, that 1 year birthday. And people could break it up how they wanted. Most groups broken it up by trimester. It was just simpler that way because it matches the pregnancy period. But we wanted to identify what are the things we are doing, what are the things we're not doing, what are the pain points, and what are we really asking of families versus asking of the maternal health system itself. We found we ask families to do about 76 different things in those first 6 months that they're pregnant, and we are responsible for 5, collectively. We found that at that time in Kansas City, if someone had a loss, a fetal infant loss, or a post-birth loss, home visiting programs didn't keep them because they were no longer pregnant or parenting. Well, when do you need the support the most? Is when you have a loss. Why is that? And it wasn't identified in any of their guidance that they had to do that. They just didn't keep them. Also important to note, none of them ever had anybody that had a loss, which meant that we were not capturing the right people and we were not engaging the right communities, and that is on us as an MCH system. That's our onus. We have to own that. But one group on the spot said, wait, why don't we do that? We're going to do that. If we have a loss, they stay with us. If you have a client who has a loss, send them to us. They can be in our case management program. There's no reason they can't do that. Huge, simple fix, right? That's a systems change that happened on the spot because we talked openly about the challenges and about our programs. They didn't think anything they were sharing then was proprietary until it came time to talk about numbers. So that first iteration, those of you that are in data security are going to cringe when I tell you this. They said, Mariah, do this data network. Do you know what you're doing? And I'm like, no, I don't. And they said, you'll figure it out, just do it. And I said, okay, great, I will. So I Googled it. There's no ChatGPT to give you an outline of how to do it. So I Googled it, found some guidance. I'm like, okay, we'll do this. This sounds great. Google data sharing agreements, was appalled at how long those data sharing agreements were. I'm like, I would never sign this. I don't even know what this thing is. So I made a 2-page data sharing agreement, 2 pages, to go along with my 2-page MOU that we used as a standard for our organization at that time. So a total of 4 pages. I had 7 data sharing partners, including a hospital, with a 2-page agreement. The group also came up with a collection of indicators that they wanted to collect to determine the state of maternal health in the region at that time. It was over 200, with sub-indicators underneath those, so really more like probably 400. And I'm like, no. Just off the fresh hills of my dissertation analysis, where I did a hand review of 10,000 charts because the data I wanted wasn't structured. I'm like, I'm not doing that again, ever. We're not doing this, we're shortening it. We got it down to about 125 indicators that fit into 9 categories, recognizing that not every entity is gonna collect all this information. Some do, some don't, that's okay. And that's what we collected in the beginning. COVID happened, everything paused, because everyone involved in the work was frontline responders, so everything paused. In 2023, I started having conversations with people again. What do you think about bringing this back? Do you still want to do this work? If not, we're just going to shelve it. But do you still want to do it? I saw value in it, but this is a collective effort again. It can't just be me. And so they said, yes, let's try to do this again. I was able to secure multi-year funding from regional funders. I found a tech platform, which is great because here's the piece data security is going to hate. Everything was stored. They were all Excel files, de-identified, stored in a locked folder on my desktop, which I can finally retire because that has been pulled off and put into our network. So it is in a safe space. But that folder didn't connect to the internet. Our IT guy did whatever magic thing he did to make sure that folder did not connect to our OneDrive and was only on that desktop. So it was the most secure possible thing that we could do at the time. Now I have a platform that's cloud-based that meets all the security levels, which is great. But it was rudimentary, very rudimentary. And like, this is not going to work. So I need to have a platform partner. So I found a platform partner through a lot of conversations that I had and a part of other work I was doing with other entities. And they're local to Kansas City. And they already collect data from large academic and clinical institutions where he does work with like sepsis prediction and things like that, things I don't understand. And so he's our platform, and I get it at a very good cost because he's really into this work, and he's like, yes, we have to have some type of data sharing. This is something we need to do. So I have him. I have support from groups like BioNexus, the Center for Bioethics, Casey Digital Drive, and Casey Digital Health, I think I always get, they're related, but I get their names wrong all the time. They sit on my governance groups. In fact, John from Casey Digital Drive and Honorok, who's my platform about health, they are in on every conversation with new prospective partners about sharing because I can't answer questions about the technical side. Honorok can. There are things I don't understand about how data is structured within EHRs, but John, that's what he did for Cerner globally, so he knows that work. So they are my tech experts who help in this piece. But we are not that rudimentary piece anymore, so I just wanted to give that guidance so you know where we were at and how far we have come, because we have come quite a ways since then. So our governance structures at this network. So we have a steering group and advisory group. These were pulled down and developed off of NIH guidance from their data sharing network toolkit that is intended for federal data sharing networks. I stumbled across that toolkit and was like, oh, this is good, I'm gonna grab that. Took out the pieces that don't apply to us because we're not a federal entity, and there was quite a bit that didn't apply to us, but took those pieces out. And so our governance structure mirrors the NIH standard as of in 2024, 2024, mirrors that standard. So it's diverse organizations that sit on our panels, our two governance groups. So it is the Center for Bioethics, it is BioNexus, Casey Digital Drive, Digital Health Casey, that's how you say it. I have hospitals that sit on this. I have data scientists that sit on it. I have academic centers. I have community-based organizations. I have an FQ. I have a health policy analyst that used to work for the federal government who sits on it because she understands how it's done and interpreted on the federal side. I have healthcare policy experts that sit on it, and I have community members that sit on it too. And we have subcommittees or ad hoc groups that are developing our rubric to test projects, that are ensuring that we have ethical guidance and guidelines, that are ensuring that we're meeting the expectations and outcomes that we've set forth. I do have some research experts on it, but it's important to note that all the data in this platform's purpose is QI/QA. There isn't an IRB component at this time. There may be in the future, but that requires a different level of consent and a different level of agreement with each institution. And so right now we're keeping it simple, so it's all quality assurance, quality improvement. This is how the structure works. So I didn't know there was a position called Office of Chief Data Officer. That's a federal term that I was told I should keep, so I kept it. Technically, that's me. Technically, it shouldn't be. When we have more secure funding for the network and longer-term funding, I'll hire someone who knows what they're doing, and they will be that person, and it won't be me. And then we have our chairperson for the steering committee, who at this time is our data program manager in our organization. But as soon as I think I'm going to have the funding to hire someone as a program manager pretty soon, specific to just the network, they'll be joining, and that'll be their role. And then we have the data steering committee, data advisory group, and then our subcommittees, ad hoc groups that come up out of that. So our values and priorities are pretty standard. This is what was standard for the NIH guidance, and we kept it. We decided not to drill down further because we want it to be a living document, and things may change. We may have different priorities and different values. These are standard ethical values for data sharing. So protecting data privacy at all times, information security, accountability, data integrity, non-discrimination in the collection of data, and these are on the onus of the group who is sharing data with you. They have to attest to these. Equitable data access for people that are accessing our platform, that we are leading innovation in the work, and that we are conducting ourselves as a professional group. So we have now a unified and secured platform. Data comes in from partners in whole record at this time. We have one entity that will not be giving us whole record, and that's because of how they collect their data. They don't have whole record data, but we do have identified whole record data coming in, and that data sits in each entity's private vault. So your data, if Blue KC or wanted to share data with us, which I would love it if you did, it will be in your own private vault that does not touch anybody else's data. If someone wanted to come on and do a project, if Alex wanted to come on and use his amazing data analytical skills to do a project and ask a question that would be answered by our data on the network, he would submit an application that would be means tested against a rubric that has been developed. He would have access to his own private portal space where he can analyze that data. And the question that he asks, let's say it's, what is the maternal health outcomes for people who receive third trimester, first-time access care, are unhoused, and, I don't know, have a car, have transportation. Our network will pull data that could answer that question from every source, so from every vault, into his private space to analyze that data. And it's analyzed with SPSS or SAS. It is preferred that you have your own license that you can then, this is a magic data gnome piece I don't understand, that he can somehow incorporate into the platform. And you are analyzing basically on your own software within the platform. And you can download your insights, but you cannot download the data set. And that's because the data remains owned by the entity who shared it to begin with. And if Blue KC said, I don't want to do this anymore, and they pull their data out, there is no downloaded data set out there that has their data in it. So it really is your private data set. So that to say, we have to be able to say that that question is for the greater good. That's one of the means testing in the rubric that we have. Is it going to answer the greater good, or is it to get a leg up on a competitor? Because that's not what we want. But we also have to make sure that it's going to increase innovation, that it's going to be somehow used for fair and equitable access for care, and that Alex has fair and equitable access to the data. Meaning, if Alex doesn't have that experience or knowledge or license, then how do we best support that? And that's one thing that we just started talking about. What is that going to look like? Because we've been asked now, how are you going to do this? And our intention, and what we've already have a couple of yeses from some academic centers, is their graduate students. It'll be part of their project work. One center is like, we can make it a course. And I'm like, oh, that may get into things that I'm not comfortable with, but let's see. But it also can build sustainability for the network too, because if you are wanting to have your med students do research or do quality QA, no research, do QA work, then you need multiple access points. So you have to pay for that. But CBO down the road is never going to have to pay to access the network, because they need to have, that is what equitable access is. But maybe Blue KC does help to financially support the network because they find value in it. So we're hoping our larger partners want to support the network ongoing because they find value in this work. So what we're doing right now to grow, and we've already met most of our milestones. I'll show you the timeline in a little bit, which is fascinating because this was put together 2 months ago and we've already met most of those milestones. I'm so happy that we've done that. Is to grow our data sharing partners. Right now, we have 2 clinical groups that have data coming in to our data network. In addition to my organization's data, it's all in there as well, and our previous data. We have 6 different large clinical institutions who have the now 57-page agreement package. It's a package now that has everything in it, that's working their way through their systems, and one of them is expected to sign in the next couple weeks, so we'll have that entity's data being shared. We have several CBOs who are putting the process through their means testing to make sure that they want to do this, that's being signed, and we have, I'm happy to say, all 3 prominent referral networks in Kansas are engaged in active conversations with one of them bought in. And they're just waiting for their governing entity to sign off on the paperwork. So I'm gonna get referral data, which is amazing. I thought it's really cool. That hasn't been shared yet. So I'm super excited. We're gonna do a gap analysis once we have enough data on it. The rate things are going, it should be mid-first quarter. And this depends on the larger clinical institutions sharing data in, because we can't do a gap analysis if I don't have their data yet. So it depends on how long those contracts take, because that can take a long time to get through some of their systems. But it's looking like mid-first quarter, in first quarter, we're gonna have enough that we can conduct a basic gap analysis and identify what's currently being collected and what are we missing. Transparency in everything. It has to be transparent. If it's not, then we're not doing it for the greater good. I don't care if someone copies me. Go for it, please. And show me that this is a model that's effective and works. Because we can't just do this in a silo. I can't just own this work. It has to be something that is collectively owned and replicated. We've been asked to add community health worker data across the state, not for the state, across the state. And we're going to do that, and we're able to do it at a lower cost because we already have this in existence. We just need extra storage, basically. Extra technology storage, all that special vault stuff has to be done. And then we also want to make sure that reporting is done in a way that is fair and transparent. As a network, the only reports we're going to produce are gap analysis. And then like how many users, that kind of stuff. We're not going to be reporting, what the actual health outcomes are or the actual landscape, because that needs to be done by the people who are asking the questions on the network. The one thing that we ask is that they cite us as their data source. That's it. Pretty simple. And focus on sustainability. We can't be grant funded forever. It's great that we are right now, but we need to have a long-term investment in this work. We are not, that doesn't mean I'm going to like venture capital, because this is not a profitable thing. It could be a profitable thing, but for us, this is a nonprofit greater good thing. So who wants to put their community benefit dollars in this? Who wants to commit to long-term supporting this? Which is why the idea of having like med students using this as a platform for some of the research work they have to do that's required, that's exciting. That's a way to build sustainability. Having our larger entities like payers and health systems pay in to help support the network, that's a good sustainability piece. That way it can remain accessible for our smaller organizations who just don't have the ability to afford data. So those that want to know tech, here's how it works. There's magic data gnomes, like right here in the data cleaning space. So when data comes in as a whole data set, it's like as a whole record that's identified, I don't understand how it works, but Anurag has assured me it does this, and I know he does it for other stuff, so I know he does, but it will anonymize the data. It won't de-identify it, because we are going to want to link records if we can. So it will be anonymized data, and he has magic data gnomes that clean the data and anonymize it, which is amazing. But it also only does that when it's pooled into a research portal, what we're calling them, the data set portal. It doesn't anonymize it on, I'm going to use you as an example again, it doesn't anonymize it on the Blue KC vault. It's identified in there. It anonymizes it when it requests it to come through to answer a question. That way we can link data. The other important thing I didn't mention, you can't give me data older than a year old. I don't want your old data. I can get that. I want your current data. What we're going to define as current for population health level data is a year to 18 months. Now, eventually, we'll have a longitudinal data set. If you want to give me 3-year-old data, it better be 3, 2, and 1-year-old data. There's going to be a need for some historical look back, but I don't want old data. I don't want data from 2022, and that's what you had to share with me. No, I'm not going to play with that. I'm not even going to entertain it. That is not current data. That is useless. I want current information that can tell us where we are and where we need to go. That is integral to this work. We also recognize some smaller groups may not have the ability to give us current data, our definition of current. So they may need to give us a little bit older data, and we'll discuss that with them. They may have their system may be a spreadsheet. So we're gonna talk with them about how to work with that to upload what we need. And I do know that in this access control spot right here, right there, if an entity is trying to download the data, they'll get a warning. If they try it again, their access is shut down. It's something we're not doing. We have to protect our entities. The only reason I've been so successful with getting clinical institutions to share data with me is because I'm a neutral party. I am not their competitor. It is not housed in an academic setting. It is not housed with another clinical entity. It's housed in a neutral setting. So we have to make sure that it remains neutral. That's also why we will not conduct a gap analysis until we have enough partners of similar size sharing data. Because if you really wanted to identify how many babies were born at, I'm just gonna say Advent because they deliver half the babies for Wyandotte County. If you wanna know what hospital Advent is, which they may or may not be a sharing partner, you could tell by downloading a data set or analyzing a data set for birth zip code of the place they gave birth. You would be able to tell any hospital. You'd be able to tell. So we have to make sure we have enough entities on, and if someone requests the zip code of where someone gave birth, they're not gonna get it. Because that is trying to identify a possible competitor. Now, if Blue KC came on and they wanted to know something that was identifying for them as a question they wanna ask, we'll give it to them because that's their data. But we're not gonna give it to them for somebody else. So there are things in place to make sure we don't have issues like that. Oh, Kansas Plan, sorry. I just see blue and I think, oh, you're all the same. I should know different. Blue, I'll just say blue. And then the analytics and news publications, that's where our partners come in. That's where they come in. So our timeline, 2025. I got multi-year funding in the beginning of 2024. So in 1 year, we have done everything I've told you. That's a lot of stuff. I think we're moving too fast. And I've been told we are moving really fast. But I also recognize I'm not going to slow down the momentum either. So we're just going to keep going. So where are we at right now? We are actually in the Q3, Q4 right here to expand data sharing partners and expand staff. I'm actively looking for funding, and I may have secured funding for a part-time program manager to run this. So if you have money, I want it. Let's get this going even better. And moving in 2026 to a larger network, and that's when we're going to include community health worker data. We've also been asked to include other chronic disease data states, which we can. There's no reason you can't include anything you want on here. And also SUD. And I'm a little hesitant with the substance use because there's some extra protections that need to be put in place. It's a protected population. But, I mean, we can try it. We can see what happens. So my goal, though, is to add the CHW is the next one I want to add, and we are really close. Probably Q1 will be adding that as well. And so here's my sources for my data, my one data slide up top, and the references. And then these are the groups that we have that I pulled information from. So if you want to know where we got our stuff, again, transparency is super critical. There you go. Charlotte Data Trust, ASIP, Gravity Project, and NIH Toolkits. Yeah, the slide should be available. Yeah. Yeah. Again, I share everything. What do you want? I'll give it to you. So there you go. That's how to contact me. I've got cards. Happy to answer questions. I know there's no mic, so I'll just repeat the question back so the people online can hear it. And if it's a technical question, I'll do my best, but I have to connect you with Anurag to answer those. All right. Do we have any questions? Which hospital? ACA? No, at this point, the conversations with partners that I've had are specific to the Kansas City region and does not have to remain that way. The reason I started there is because I know people there, so that's the best place to start. But it's also important to recognize that a lot of people come in from the rural communities into Kansas City because of the level of care that they have there. So if it's a micro-preemie, if it's a twin transfusion situation, if it's a very sick mom or very sick baby, you're going to be going into Kansas City. If you're basically here west or here east, you're going to go to Kansas City. And transferring, yeah, they transfer to Kansas City all the time. So are you right now? No. Do you want to be? Let's have a conversation. I would love for you to be. There's no reason you can't be. Yeah, no, oh, I know, but it's Cradle, Kansas City, because that's where we are. But my goal by 2027 is to have it in the entire state of Kansas and Missouri. And then by 2028, have it Region 7. So we're talking about adding Iowa and Nebraska. And then maybe by 2030, if we're still going and have funding, why not take it everywhere? There's no reason.
So how many partners do you have at the end of Q2?
The end of Q2 this year? The end of Q2 this year, I had no signed contracts. And in Q3, I got 2 signed contracts with clinical data being shared, and 6 are now out there in discussion. And those 6 started end of Q3, beginning of Q4. And it's because you can't tell me no. Like, I'm just gonna, well, if I didn't ask it right then. Like, I cannot. I do not have enough partners on yet. And that's another piece. Until we have enough partners on, we're not going to disclose who they are. They have said, you can say who we are. And we have, as a collective, determined we're not going to state that yet. It's also why on our website, you're not going to see much about the data network yet, because it needs to have a little bit more solid footing before we can really put a lot of information out there. So I cannot disclose. That's the one piece of transparency I can't tell you yet, is who's on the network. But I can tell you that it is clinical data of a couple of different size entities. So what role do I start with? If I have an in, I start with the person that I have an in with. Who do I talk to in your organization about this? One of the benefits of having the Center for Bioethics with James Stowe and Dennis Riednauer with BioNexus, and Anurag, who works with hospitals already, and John, who works with clinical entities because of his work at Cerner, we have a lot of people already that are pretty high up, and so we'll go straight to them. With some of the hospitals that we're talking to, it's easier if we have a champion that's a physician to help champion the conversation while we are talking to the decision maker. So at one entity, I know Family Med and OB pretty well. So those are our 2 ends. At another entity, I know rare disease really well. So that's our in there, is to talk to them, because rare disease also happens to people who can have babies. So, it doesn't matter where we start, because it all kind of affects the same population. But it's who do we have an in with? Like, for example, Josh Weimer with Missouri Department of Health and Human Services, who's leading their data transformation work, he was brought to us by the Hospital Association. And he is all on board. He's a part of our steering committee, and he's working to identify where, on a state level, this could fit in as a part of that data transformation work. I'm hoping in Kansas we can get TEMA to partner with us at Transforming Maternal Health, because I already have data. How can I share this with you to lessen the burden and ensure that we really have a better picture of what's happening and not duplicate work? There's no reason to duplicate it if we have it, and we're barrier-free. There is no magic person you have to know to get into us. It's, hey, we have a question we want to ask. Great, here's the application. We're going to means test it, and let's see what we can do to get you on. Like, it's really that simple and that easy, but with the proper protections to ensure that we do have data anonymization and that we do have integrity, and that we're not overly allowing one group over another, and that we're providing supports for groups who do not have the ability to analyze information. Yeah, the groups we're pulling data from they're clinical entities, they're academic centers that are academic medicine, they are FQHCs, they're private clinics, they're private providers, They are CBOs, so community-based organizations providing social care. It looks like we're going to get that referral network data on, which I'm so excited about. And we are in talks with the hospital associations. How do we get claims data? What does that look like? That one's a little tricky because they tell me that we have to go back to the entities that are sharing the data with them. And when I talk to those entities, they say, well, no, we share it with the hospital association and they're the ones that own it, so they can, it's just that one's going to be, I think, the hardest one to get in with. But, I mean, mm-hmm. So if we partnered with Call Hospital, it wouldn't be asking for specific data, we'd be asking for whole record. So prenatal care, labor and delivery, birth to 1 year, whole record to come across. And it's important to note, we are not an HIE. We are not doing HIE work. It does not connect this information to another hospital. The hospital can't say, I need to pull from this patient, what was their latest lab results? That is not what this is. It is also not a point of access for individuals into their health record. You cannot do that. It is strictly a data sharing platform. Mm-hmm.
I know you were talking about substance abuse, and that's kind of you have to be careful with some of those things. Is mental health assessments something you also have to be careful with, or can you ingest that kind of data?
So anything that is in the whole record, we will get. If that includes, and again, this also depends on how that institution has a whole record put together, because I have learned in my work with the MMRC and with FEMR that you can request whole record, but you may only get clinical notes. So it depends on how that entity determines whole record to come across. So could we get mental health assessments? Absolutely, if it comes across that way. The SUD question was from a couple community groups who are doing work in SUD, and they recognize that there's no central point to access that type of information. And so they asked if we could house it from entities that provide SUD services, and that's where it gets really tricky. And so if it's a part of a whole clinical record or a whole social care record, that could come across to us and it could be in there. It's like postpartum assessments, yes, that could all be in there, absolutely. Mm-hmm. And I would love to, I want it all. I want education data, I want transportation data, I want employment data, I want economic data, I want it all, because it all feeds in to maternal health, to health in general, all of it. How you walk through the world feeds into maternal health. So eventually, I'd love to have everything on there. Is that going to be possible? Probably not, but if I can get claims data along with clinical, social care, and referral data, and it looks like I'm going to get EMS data too, I think we're going to have a full picture. I think we're going to have the best picture we've ever had, and especially when we can spread it out past maternal health and get it into just general health. Oh my gosh, could you imagine what we could do with that? Mm-hmm.
But where is the state of Kansas drawing data from at this point?
I don't know. I'm not in the state of Kansas. I don't know. I know that, so in the community health worker world and in the maternal health world, if you're a funded entity from the state, they have your data because you have to report back to them. But they collect very specific information, and as a grantee, I can tell you, it doesn't tell you anything about what's happening. It tells you what they need to check the box to satisfy a requirement. So and they get vital stats data. I want long form birth certificate data. I want that. I want death certificate data. That's all good data, really good, rich data. So how can we get that in there? And those may be a little bit older, just by nature of the process it takes to get through the state and get through, because I see that sitting on these death review committees. But eventually, I want that.
Have you done any outreach with any of the organizations that Lady Down the City?
No, I haven't reached out to them quite yet, and part of that is because that's a very tricky piece, and she's asking about the groups that work with people who've had an infant loss, a fetal infant loss. It's a little tricky to get that information because it's secondhand referral to them, and a lot of times they don't even have the information that would be needed to submit. They would just have a name of a person. So it's a little tricky. Doesn't mean we can't. Doesn't mean there might be something we can do with them. It also doesn't mean that they can't use the network. Because it's important to note that there may be people that don't share data in, but they can benefit from what's in here. So you don't have to share in to access it either. I mean, if I don't get University Health to share data with me, it doesn't mean they can't access it. It just means I don't have the data on the network. Hopefully by peer pressure and maybe public shaming, I can get their data. But, you know, in the beginning, I mean, I have it. So, and I think we're at time. But I'll be here for a little bit, about another 30 minutes, and so I'm happy to answer more questions. And you guys, my email's there. I'm happy to give you my card and connect with you. Connect you to my tech partner who can answer all the questions that I cannot. Thank you so much for coming in and asking some really good questions and hearing about our network.